from Sri Ramakrishna Hospital and from the city of Coimbatore, who have logged in today for this webinar. It's one of the series of webinars being conducted by Sri Ramakrishna Hospital for the last 3 years. And on behalf of the management, I welcome all of you for this webinar. And today's speakers are Dr. Arun Gangadhar, our senior pulmonologist, who is going to talk about beyond antibiotics, understanding and managing non-resolving pneumonia. A very good topic and a topic of importance to all the practitioners. And our next speaker is Dr. Sabarinathan, a senior gastroenterologist, medical. And his topic is approach to upper gastrointestinal bleeding. So both topics are of clinical importance and useful to all the medical practitioners. And I thank both the consultants for sparing their time, take part in this webinar for the benefit of all the doctors from our hospital and from the city of Coimbatore. And I'll hand over the session to Dr. Arun Gangadhar, please. You're mute. You have to unmute your mic.
Sorry, sir.
Okay, now it's audible.
Thank you, sir. Thank you for the wonderful words of introduction. So I think without further ado, I'll share my screen if that is visible already. Will you please confirm? Is the screen visible?
Yes, yeah, visible. Visible.
Yes. Okay. So good evening, one and all. So without further ado, I'll get on with my presentation. So for the next 10-15 minutes, I'll be going through various cases of pneumonias, various cases of consolidation, which seemingly seem as a simple community-acquired pneumonia later turned out to be something more sinister. So I'll be going through the various approach, the algorithm to properly diagnose a non-resolving pneumonia, how long to wait, various gadgets that we have to sort of delve into more into the diagnosis of a non-resolving pneumonia. So in broad, this is the causes of non-resolving pneumonia. That is what is described in the literature. So first one being when it comes to non-resolving pneumonia, we know there are two main factors, two main etiologies. One is the infective one, and the 20% of them being non-infectious one. So the infective pneumonia, often pneumonia goes unresolved because of the misdiagnosis of the pathogen, or because of various resistance patterns of the organism towards a particular antibiotics, whether it may be intrinsically resistance, or whether maybe it might be acquired resistance. So these are the various causes. And then there could be host factors, like as in patient might be immunocompromised, patient might be having multiple seeds of the infections elsewhere, patient might be having multiple other complications due to the same pneumonia as such, like patient might be developing a lung abscess, patient might be having an infective empyema. So all these can be the cause of non-resolving pneumonia when it comes to an infective case. And again, 20% of cases, so we have to bear in mind that 20% of them are non-infectious causes. And again, for any infectious pneumonia, for it to resolve, there are certain factors. So these are it depends on the comorbidities of the patient. So more the number of comorbidities, more the age of the patient, more severe the pneumonia, or the more the infective the strain. So for all these factors can increase or worsen the resolution of a pneumonia as such. So these are the various the factors which we have to bear to wait how long to see for the radiological improvement. Then again, after X-ray, we have various modality to use in a non-resolving pneumonia. First one being CT thorax, and then we have bronchoscopy. Along with that, we have various other gadgets like linear rebus, radial rebus. So I'll be describing more about them in my cases as well. So this is in broad this the approach to a non-resolving pneumonia. Like so, for any patient, when we wait for the 5 to 7 days of antibiotic patient, and then we reassess based on the age, comorbidities, severity of the pneumonia, and specific pathogen, and then we see that the resolution is not really appropriate for the various factors that patient is being assessed for, and then we, if at all, if the resolution is not really appropriate, we go in with other tests. So first one that we have is chest CT. Along with that, we go in with other laboratory parameters like CRP, procalcitonin, various other infective markers to see if at all the infection is still there, whether the patient is developing more going into other other complications as well. So suppose with CT scan and suppose with all the other tests, the diagnosis is very apparent, we modify the treatment accordingly. Suppose we see that the patient might be having a fungal cause, the sputum is growing a bit of fungal this thing, we modify the treatment as well. And suppose the CT shows something sinister, we
Arun, you are not audible. Murali,
Yes, sir.
it's not audible.
Yes, sir. I think it gets stuck, sir, actually. நான் சார்ட்ட பேசிடுறேன் சார் ஃபோனில் பேசிடுறேன் ஒரே
Hmm.
Sorry for the technical glitch. I think I'll get on with my presentation. Is the slide visible?
No, sir, not it, sir. Your slide is not visible, sir.
1 second. Visible?
It is coming, sir. Yes, sir.
Yeah.
Please. Yes, sir.
Yeah. So this is my last slide.
Yeah.
So sorry for the technical glitch. So I'll get on with the slide. So based on the factors that we have, we reassess the patient when the patient is having a non-resolving pneumonia. We go in with the various modalities that we have, like chest CT. We go in with other laboratory parameters like procalcitonin, CRP, and various other serum galactomannan if the patient is immunocompromised. And then we see whether the diagnosis is very apparent. And if suppose, yes, we get some another clue, we modify the treatment accordingly. And if say the CT picks up a lesion, then we go in with other modalities like bronchoscopy if it is needed. And if there are multiple mediastinal lymph nodes, then we might have to go in with the bronchoscopy. Along with that, we might have to add EBUS or radial EBUS and everything. So these are the various the approach that we have to a case of non-resolving pneumonia. So as such,
the premise of my talk here entirely is that a simple consolidation might not be a community-acquired pneumonia as such, and it might be more sinister. So we might have to delve into deeper to see all this thing, which we do not. It is not recommended that we get a CT for every other consolidation or a small pneumonia, but yes, for a non-resolving pneumonia, along with the various clinical premises that we have, we might have to add bronchoscopy or CT or whatever. So there's a caveat to this the approach. So there are various syndromes or various conditions which are not even diagnosed by a biopsy or a bronchoscopy. So these are pulmonary vasculitis syndromes caused by C. Anka, P. Anka, cryptogenic organizing pneumonia. Although it is diagnosable by a transbronchial lung biopsy up to 50%, but most of these patients might be sick and it might not be advisable to go in with a bronchoscopy. Yes, so that is another factor, and various alveolar damages of various etiologies that we have. So these are the various factors which we can't go in with a bronchoscopy, and we might have to take a call clinically. So, what does the guideline say when it regards to a patient who's having a consolidation which is not resolving? The first thing you got to do is repeat the X-ray, repeat the investigative parameters, and get the patient admitted. So that is what 2009 British Thoracic Society guidelines says. And in view of in a scenario where the X-ray is worsening and the bronchoscopy is also negative, we have to go in with a thoracoscopic lung biopsy or even a surgical lung biopsy. So that is what the guideline says. And in Indian perspective, what we have, these are the most common cause of non-resolving pneumonia. So pyogenic causes comes number one, like lung abscess, empyema. So these factor the number one cause. And then we have the mycobacterial or fungal causes. We have various bronchogenic malignancies coming in as number three. Sarcoid eosinophilic pneumonia, they are the less common ones, but the topmost three ones are the most common non-resolving pneumonias that we have in India. So I'll be going through few cases to see to tell you a small consolidation might not be a simple consolidation. So these are the cases which I've put up. So case one, a 70-year-old admitted with anterior wall MI with LV dysfunction. Coronary angiogram showed a triple vessel disease, and the CABG was done by the thoracic surgery team. So the patient, the complaints with which the patient came in with hypoxia and hypotension, everything improved after surgery. But then on the post-operatively on the 7th day, patient was there for 7 days. Patient developed respiratory distress with hypoxia. So chest X-ray showed bilateral consolidation. Patient was put on empirical broad spectrum antibiotics as was a dictum. Along with that, suspecting persisting LV dysfunction, patient was put on BiPAP along with oxygen supplementation as well. So all the infective parameters turned negative. LV function, to our fortunate this thing, LV function was better than what the patient came in with. So this is how the X-ray looked like, and then we got a CT scan done for the patient. So what this shows is bilateral consolidation pattern bilaterally with a bit of pleural effusion, more so in the right side as well. So this is what we call an organizing pneumonia. And as such, the patient was put on IV steroids as well. Along with that, the prophylactic antibiotics was continued. Along with that, an IV BiPAP and a supplementary oxygen was continued and tapered and was stopped after a couple of days. And the patient improved. So this is how the improvement has been in the next 3-4 days. Sorry. So patient improved clinically. Oxygen was the oxygen supplementation was tapered and stopped. Patient was discharged after 7 days of IV steroids. And so the second case, we have a 60-year-old gentleman, a known diabetic, who came in with peripheral vascular disease, and he was admitted under plastic surgery team, and he was planned for a debridement surgery. So incidentally, patient complained of a cough and a shortness of breath of 7 days duration, which was not very severe, but nonetheless, patient was complaining of these complaints. And as such, patient was having bilateral pedial edema as well. 2D echo was not grossly inadequate. The LV ejection fraction was 55% and bit of diastolic dysfunction as well. So what do we see? We see that in X-ray, we see that there's a bit of right lobe of consolidation with a bit of CP angle blunting as well. So, so CT showed pick up the clue here. So CT, what it shows is the right side consolidation. Along with that, pleural effusion bilaterally. Along with that, we picked up all these interlobar septal thickening, which is quite diagnostic of a fluid overload pattern. So in this patient, the heart failure with a preserved ejection fraction was diagnosed, and as such, patient was put on diuretics and decongestive measures, and as such, patient improved beautifully. So this is the X-ray after 5 days of steroids. So respiratory distress and cough, everything settled, and patient was discharged on diuretics as well. In the third case, we have another 58-year-old with no prior comorbidities. Mind you, he's a non-smoker. He had complaints of cough and shortness of breath of 15 days duration. And the chest X-ray showed a small perihilar opacity. Patient had taken multiple course of antibiotics, bronchodilators from elsewhere in these 5 days. Sorry, in these 15 days. So if you see, there's a typical left-sided opacity here. So left-sided opacity, and very well that is seen in the CT scan as well. It's a peripheral nodule, not very big, but nonetheless, we went ahead. We did this procedure called radial EBUS, which is sort of a new novel measure, novel bronchoscopic technique wherein we put in a scope, and by ultrasound means we go in till the peripheral lobe. We see where the mass or the nodule is located. We take a biopsy out of it, and we come out of it in toto. So, and for this patient, because the CT showed a bit of mediastinal lymph nodes as well, we did a linear EBUS for staging. So, the immediate proximate lymph node was negative, and the biopsy of the from the radial EBUS showed in situ adenocarcinoma, which is a localized adenocarcinoma, which means the patient is amenable for a curative surgery. So as such, we took him up for a left lobectomy, which was curative in fact. And the biopsy specimen which we had taken, it was positive for EGFR mutation. So as such, post-operatively, patient was put on osimertinib as well. And it has been, we have been following this patient for around 4 to 5 months now. Patient is doing very well. In this case, a 54-year-old gentleman with no prior comorbidities, patient had a complaint of cough, fever, shortness of, sputum production of 1 month, and patient has been complaining of shortness of breath of 10 days in duration. So chest X-ray showed non-resolving right upper zone consolidation after empirical antibiotics. So as such, sputum was not really forthcoming, and we took him up for a CT scan, which shows the typical consolidation with the bronchectatic pattern in the right upper lobe. So what did we do? We took him up for a bronchoscopy, and bronchoscopic lavage showed AFB smear, which is positive, and the TB NAT, that is gene expert, came negative. So any guesses what it could be? It is a non-tubercular, non-mycobacterial infection. So in that, non-tubercular mycobacterial infection. So as such, patient was empirically started on these 3 drugs. So these are the 3 drugs which is recommended for any patient with NTM infection: rifampicin, ethambutol, and azithromycin, provided we have sent for AFB culture reports. And AFB culture for this patient revealed Mycobacterium intracellular infection. So this is a treatment we continued for this patient. The same treatment was continued. And so again, this patient, this is very recent case. So patient has been continuing for around 2 months now. Patient is tolerating the drugs as well. So with this, I conclude the take-home message I would like to put out is that prompt referral is the key in most of these cases. If you've seen that the 4th case, wherein the patient with the diagnosed adenocarcinoma, because the patient came to us early on with 15 days of history, we could pick up the disease fairly on, and as such, patient had a curative surgery, and it changes the entire life asset, quality of life asset. So very often we have to have a multidisciplinary discussion with the radiologist, with the surgeon, everyone who's involved, and again multi-modality approach as well, with the CT scan, often using bronchoscopy, lung biopsy, EBUS, and we have to stop the over reliance of antibiotics. We have to have a judicious use of antibiotics along with an antibiotic stewardship. So that is all. Thank you for the patient hearing. I'll be happy to take any questions if there are any.
Thank you, Dr. Arun.
Thank you,
I
sir.
think your question answer sessions we'll have at the end of the second.
Sure, sir. Sure, sir. Sure, sir.
Thank you. Dr. Sabari?
Yes, sir. Good evening, everyone. My slide is visible, sir? Yes.
Yes, sir.
Yes, visible. Yeah.
My top, yes. Good evening, everyone. My topic is approach to UGI bleeding. Upper gastrointestinal bleeding is a medical emergency, so we thought this will be a useful topic for the general practitioners and attending physicians. To know about the epidemiology, upper UGI bleed when it compared with the lower UGI bleed, it's a 5:1 ratio. So more commonly we see the upper UGI bleeding. 80% is self-limited and 40% caused by the peptic ulcer. So 5 to 10% it can be a severe bleed, in particularly in patients with the elderly people and the cirrhotic patients. The mortality goes up to 5 to 10%. And if they have a rebleeding and or continue to have bleeding, the mortality rate goes up to 30 to 40%. So to say it's upper gastrointestinal bleeding, the bleeding is starts above from the suspensory ligaments of treats. That's the anatomical area where we define as a upper gastrointestinal bleeding. Coming to the causes of upper GI bleed, we classify into non-variceal and variceal. Among the non-variceal, peptic ulcer, the frequency is about 38%, followed by esophagitis, upper gastrointestinal tract tumors, and some conditions like angiectasia, malarious tear, and some erosions, Dulafis lesions. So these are the causes for non-variceal bleeding. Variceal bleed, it could be from either esophageal varices or gastric varices or ectopic varices. So it accounts about 16%. The clinical features, patients will have hematemesis. Hematemesis is vomiting of fresh blood or old blood proximal to the treats ligaments. Bright red blood indicates it's a significant bleeding, or coffee ground emesis. It indicates there is no active bleeding. The patient already had bleeding. So they will present with the coffee ground emesis. Melena is a passage of black and foul smelling stools, usually from the upper source. It can arise from the right colon also. Hematochezia is a passage of bright red blood from the rectum. When there is an UJ bleed, and if it is a very brisk bleeding and very significant, and people will have a very rapid transit in the upper in the intestine, they will have a hematochezia also. So the occult bleeding, the bleeding is not visible. So from the patient's history, we can able to identify the site of the bleeding and also the cause of the bleeding if we elicit adequate good history. And we can differentiate as per the history whether it is related to the peptic ulcer disease or chronic hepatitis, cirrhosis, and history of anticoagulant, antiplatelets, NSAID, alcohol, binge, steroids intake. All these factors are very important in dealing patients with upper GI bleed. So we can find out what is the particular etiology and the history of coagulation disorder, blood disc crisis, and we should elicit the history of epistaxis or hemoptysis also. Clues for upper UGI bleed as per based on the history. Patients will have a multiple emesis before hematemesis, or with a history of alcoholism, retching. It indicates the condition called malarious tear. Dysphagia, odinophagia, and reflex symptoms indicate esophagitis or esophageal ulcer, epigastric pain, NSAID intake, aspirin use, pointing towards peptic ulcer. And patients in hospitalized patients with burn sepsis and etc. indicates a stress gastritis. and with a history of alcoholism, cirrhotic liver, so we can diagnose as variceal hemorrhage or portal hypertensive gastropathy. And a history of renal failure and cirrhotic patients, they will have a conditions called gastric antral vascular ectasia, shortly called GAVE. And the important clinical history like weight loss, dysphagia, cachexia, early satiety, pointing towards the malignancy, gastric cancer, particularly in patients aged more than 45 years. That's called late onset dyspeptic symptoms. So these are all the alarming symptoms. With along with the history of upper GI bleed, we can suspect a gastric malignancy. And angiodysplasia is common with chronic renal failure and hereditary hemorrhagic telangiectasia conditions. Rarely, aortic enteric fistula will present as a upper GI bleed. On clinical examinations, we should focus on the basic vitals, pulse rate, whether the patient is having any tachycardia, hypotension or orthostatic hypotension, whether the patient has a tachypnea that indicates aspiration. And we should look for pallor, icterus, and epistaxis, postnasal bleeding. And we should see for the skin changes. We can see any purpura or any other skin lesions. So petechiae purpuras, that indicates a low platelet or any vasculitis related conditions. And we have to see for the signs of liver cell failure like palmar erythema, spider angioma, and bleeding diathesis like purpura and ecchymosis, as I said, and coagulation disorders, hemarthrosis, and muscle hematoma. All these things are very important when we deal the patients with upper GI bleed. The clinical examination will give the accurate clue. And per abdomen examination, we have to look for any tenderness, any moss lesion, like that. And also to look for hepatosplenomegaly, ascites, caput medusa. All this indicates cirrhotic liver. So to conclude, to when we approach the patients with the GI bleed, and immediate initial assessment is the very important factor, and we have to stabilize the patient, and we have to identify the bleeding source, and stop the active bleeding and treat the underlying conditions, and we have to prevent the recurrence of bleeding. So when we have a patients with upper GI bleed, we have a risk stratifications. We have got various scoring systems like Blackford, Clinical Rockall score, and AIM 65. And this is pre-endoscopy scoring system. And some of the scoring system has got a post-endoscopy scoring system like Complete Rockall, Baylor scoring system, CIDR, NSI. These are all the various scoring system used for upper GI bleed. So this chart indicates the Rockall scoring system, where you have got 0, 1, 2, 3 points based on the age, pulse rate, blood pressure, comorbidities, and the endoscopic stigmate of recent hemorrhage. So after endoscopy, we can include what is the finding. So all these factors combined together, and we can make a final score. What is the Rockall score? And based on that, we can classify the patients whether he has got a low risk, intermediate, and high risk. Low risk means 0 to 2. So among the patients with the low risk category, they will 80% recover spontaneously with the medical treatment, proton pump inhibitor, and hospitalization for 24 hours, and maybe discharged if there is any events. The intermediate risk, based on the score between 3 to 5, the same treatment is applicable, and hospitalization is slightly prolonged for up to 48 hours. And after that, we can discharge the patients. High risk patients, the score is more than 5. The treatment is the same, but they might require a hospitalization in ICU also. So this comes under high risk category. So the role of a nasogastric lavage, the benefits is bloody aspirate confirms the upper GI bleed, and better visualization during the endoscopy, and give a crude estimation of rapidity of the bleeding, and prevent the development of hepatic encephalopathy in cirrhosis, and increases the pH of stomach, hence decreases clot dissolution due to the gastric acid dilution. But the point to be noted is a negative aspirate, about 16%, does not exclude the upper GI bleed. If there is no bleed in the nasogastric lavage, doesn't rule out any upper GI bleed. And the role of endoscopy, that is the main role. And persistent active bleeding patients may require urgent endotherapy, that is less than 12 hours. So within 12 hours, it's called urgent endoscopy, and we can go for an elective endoscopy, that is 24 to 48 hours of bleeding. So we use a classifications called a forest classification, where you have class 1 3 or class 1 to 3, 1A 1B, and among the class 2 A B C, and class 3. So class 1A means a spurting bleed. This has got a high risk of rebleeding, 60 to 100%. Class 1B is oozing blood, 50%. And class 2A is a non-bleeding visible vessel. 2B is adherent clot. 2C is a flat spot in the a flat spot, and the third one is the clean based ulcer. So as the class increases, the rebleeding rate also reduces. So next we will see about the various endoscopic therapies used in patients with the UGI bleed. The basic one is injection therapy. So it reduces the blood flow by the local tamponade effect, and the use of vasoconstricting agents further reduces the blood flow. We inject 0.5 to 1 ml aliquots of epinephrine diluted in 1 in 20,000 via a sclerotherapy needle into 4 quadrants of the ulcers and within 1 to 2 mm of the bleeding side. So this will cause tamponade effect. This is called injection therapy. So the next one is a contact thermal therapy. So we have a bipolar cautery that is most extensively used. Advantage over heater probes is that it can be used as perpendicularly or tangentially, and bleeding vessel is compressed and then coagulated. So low voltage current is used for duodenum, and the end point is the vessel flattens out and there is no bleeding. So this is called a contact thermal therapy. The next one is organ plasma coagulation. This is a non-contact electrocoagulation. We have got a side firing catheter and a forward firing catheters. The high frequency monopolar current conducted to target tissues through a ionized organ gas. So 20 to 80 watts of electricity is used. 0.5 to 2 liters per minute of organ gas flow is used. So it can be done like patients with a portal hypertensive gastropathy, or with patients with a GAVE. It can be used every 2 to 6 weeks interval to ablate the lesions. And coming to the mechanical therapy, commonly used is a hemoclip. Hemoclip we can apply over the site of the bleeding, over the bleeding vessel, and it is the therapy of choice in obvious arterial bleeding. Endoscopic hemoclips are widely used, and advantage over cautery is the tissue damage is reduced, and the rebleeding rate is also reduced. We have got various size of hemoclips. So combination therapy means it's provided a durable control of bleeding than the monotherapy. Typically involve injection therapy combined with the thermocoagulation or with a hemoclip. And we have got a hemo spray also. This spray is applied over the bleeding area. This will cause a transient arrest of the bleeding, probably for 24 to 72 hours. But this can be used as a last option, or as a bridging therapy also we can use hemospray. So we will see some interesting conditions like a Mallory Weiss tear. It's a mucosal or submucosal laceration at the G junction. It's because of sudden rise in the intragastric pressure, combination with a shearing effect caused by the negative intrathoracic pressure. So non-bloody vomiting with excessive retching followed by hematemesis with alcohol abuse. Patients will have a retching with vomiting followed by hematemesis. Particularly in patients with alcohol abuse and binge drinking, we can suspect a Mallory Weiss tear. And predisposing factors like hiatus hernia, retching, coughing, hiccups. And endoscopically, we can see either a clean based bleeding or oozing or active spotting. So most of the time it is self-limited and mild, and it will heal completely within 48 hours. So we can go for endoscopic therapy like epinephrine injections or electrocoagulation, hemoclip, or we can use banding therapy also to arrest the bleeding. The conditions called cameral lesions is a linear erosions or ulceration in the proximal stomach at the end of the large hiatal hernia near the diaphragmatic pinch. During the retroflexion of the stomach, we can see the large hiatus hernia and some ulcers in the protruding gastric mucosa. It caused by the mechanical trauma and local ischemia, and people will have a slow GI bleed and iron deficiency anemia also. So the treatment will be like iron supplements and oral PPI therapy. So ulcer hemorrhage in hospitalized patients, this is very important in our settings where we have got a large number of hospitalized patients, and patients will have a sudden bleed, either a hematemesis or they will have a melino also. Most of the times it is a stress related mucosal injury or a stress ulcers, and people will have a diffuse bleeding due to erosions or superficial ulcers, and extremely sick patients in ICU, and it causes by the decreased mucosal protection and ischemia. So there are major risk factors like major trauma, post-surgery, third-degree burns, and ventilator dependence, coagulopathy, and patients already on aspirin and NSAIDs. And it can be a large focal or chronic painless also. So we need to do an urgent endoscopy, and then we need to start on PPI therapy, and we should go for a endoscopic therapy also, combination of endoscopic therapy, as I said earlier. So Delafield lesion, it's a large 1 to 3 mm submucosal artery protruding through the weakened mucosa. It commonly seen in the gastric fundus of the stomach and within 6 centimeter of the G junction, and it can be seen in the duodenum, small intestine, and colon also. So non-bleeding visible vessels or adherent clot without an ulcer also it can present, and it will cause a intermittent bleeding. People will have bleed when you do endoscopy, it will be normal, again they will have a rebleed. When you submit for a next endoscopy, you can make a diagnosis of dura phase lesions. And endoscopic Doppler ultrasound also used to show the flow of the bleed. So endoscopic management is same like injection therapy, thermal probe, or clip device, or we can apply the band also. So this is one of the rare condition. Aortic enteric fistula can present as upper GI bleed, and it is self-limited herald bleed. It can be acute, massive, associated with high mortality, and it can be a primary or secondary. Primary, native abdominal aorta at D3 part of the duodenum. History of an abdominal aortic aneurysm, and on palpation we can see the pulsatile abdominal mass. Secondary, it is due to proximal end of the endovascular graft, and D3 people already undergone endovascular graft, they might present with aortic enteric fistula. There is no role for endoscopy. We need to submit for emergency surgery. Then we will see the variceal bleed. Variceal bleed, it occurs because of the portal hypertension, where HVPG more than 12 millimeter of mercury. Mortality is about 30% with each bleed. The long term survival rate less than 40% after 1 year with the medical management alone. So initially we need to start the medical management. When we suspect a variceal bleed, we need to go for vasoconstrictors like vasopressin, terlipressin, somatostatin, and octreotide. We use different combinations. Like either we will start on octreotide or somatostatin or terlipressin. All the drugs are used in our hospital setup. And earlier they were using like a pressure technique, Sangstakan, Blackmer 2, Minnesota, Lintus, Nicholas. And the balloon tamponade provides the initial control of bleeding in 85 to 98%. So the balloon is inflated up to 24 hours. Nowadays, this balloon application is not practiced because of the improved facility and early arrival of the patient. But still, we can use as a bridging therapy, where you have a patient with upper GI bleed, massive bleed. When you are referring the patient to a tertiary care hospital, you can apply the Sangstakan Blackmer tube, and you can send the patient to this hospital. So that will have a tamponade effect that will reduces the patient mortality. At the same time, it also associated risk factors like aspiration pneumonia, esophageal rupture, and airway obstruction. So one should be very careful when you apply a Blackmore tube. So endoscopic management of esophageal varices, we go for a banding technique, where we apply the bands just above from the GE junctions up to 5 centimeter, and we can reduce the bleeding. The other form of endoscopic therapy in patients with variceal bleed, earlier sclerotherapy was used, but nowadays it is not suggested in the guidelines. Only banding therapy is suggested. But still, if they have a very small varices, and if you could not able to band the varices, you can go for a sclerotherapy, like sodium tetradecyl sulfate, and also glue injections can be used. So this is the one of the stent available. This stent is called LR Denny stent. You had done the banding, but still patient has got a rebleeding, ongoing active bleed. We can apply this Denny stent through endoscopy, and it will expand, and it will compresses the varices and the bleeding points. We can remove the stent after 5 to 7 days. So this is used in patients with undergone banding, and again they present with bleeding. So glue injection therapy is used for gastric fundal varices. So where we inject glue injection in the form of 0.5 ml or 1 ml at the different sites to make the cast and to prevent the bleeding. This is the advanced technique, endoscopic ultrasound guided coil embolization used for gastric varices. In our hospital, this procedure is started. Almost more than 10 patients underwent US guided coil embolization. And after coil embolization, we apply glue injection also. It's like a combined coil embolization and glue injection to have a better effect. And for conditions like portal hypertensive, gastropathy, or GAVE, we go for organ plasma coagulation. We have got organ plasma coagulations where you can apply the organ gas at bleeding sites and over the GAVE, and every 2 to 4 weeks you can repeat the procedure until complete obliteration of the findings. So to conclude, initially we need to stabilize the patients with the UGI bleed. We need to assess the airway, breathing, circulation. If signs of shock, and we need to transfuse blood, and we need to stabilize the patients. Then we go for other therapy. We need to classify the patient whether he has got a variceal bleed or non-variceal bleed. Good history and clinical examination, we can make sure this patient has got a non-varicose, this patient has got a varicose bleed. Accordingly, we need to treat the patients and offer the endoscopic form of therapy, so we can save the patient. Thank you so much for the patient listening.
Thank you, Dr. Sabarinathan.
Thank you, sir.
Any questions from the audience to both the speakers, Dr. Arun Gangadhar and Dr. Sabarinathan? Any discussion from the audience, from the participants? If there are no questions or any comments, then I thank Dr. Arun Gangadhar and Dr. R. Sabarinathan for taking their time out and participating in this lecture, after accepting our invitation and spending their valuable time. I thank both of them once again on behalf of the management, and I thank all the participants in this webinar, and we hope to meet you in the next webinar next month. Thank you very much.
Thank you, sir. Thank you so much.
Sir.
Thank you, sir.
Thank you, Murali.
Thank you, sir.